Good afternoon, everyone. Thank you for being here with us on our Tough Stuff discussion series. I'm very excited with our speaker who's here with us today. I've had the opportunity to work with her on different projects through the Finger Lakes Geriatric Education Center. And I recently heard this talk at the Grand Rounds that was offered and just thought it was something that we needed to hear here in Tompkins County. So I'm going to read a little bit of an intro, even though I don't feel like I need to read an intro, but I want to do her justice. And our speaker today is Dr. Muniak, who is an assistant professor of medicine in the Division of Geriatrics and Aging at the University of Rochester. In addition to her faculty appointment, she is a busy clinician caring for patients at Highland Hospital and the Highlands and Brighton nursing home, where she also serves as the medical director. She is a passionate medical educator, teaching in multiple university venues to medical students, residents, and fellows. Additionally, she serves as the associate program director of the URMC Fellowship in Geriatrics and Aging. She has recently completed the Geriatric Academic Career Award and a 4-year career development grant funded by HRSA. Her current projects include regional leadership in University of Rochester Medical Center's Project ECHO, the Geriatric and Mental Health and Long-Term Care, Age-Friendly Health System Quality Improvement Initiatives, and she is a member of the American Geriatric Society and AGS Ethics Committee. I have to just say thank you for your work in the geriatric field. As many of you know, and maybe some of the students joining us today are unaware of, there is a huge shortage in our geriatric field, and it is heroes, and I say heroes like Dr. Muniak, who really help us in the aging field. So I, with no further ado, want to turn this over to you so that we have time to hear your talk.
Thank you so much, Karen. It's an honor to work with you and have partners. I'm very excited to be here today. You just make my day, even having been invited to this great audience. I'm going to share my screen real quickly. Hope everyone can see that. Not in presenter mode. Again, the goal of today is really to, I think, shed light on a topic that is under-recognized, especially in medicine, but as we'll see, it's somewhat ubiquitous. And again, the origin story, I'm a doctor, I'm a geriatrician, caring for older adults is my life's passion. And it was really the origin story of this talk. About 8 years ago now, I started at a nursing home in Rochester that was one of the few that actually took larger patients into it, because I don't know if anybody knows, it's a lot of nursing homes just won't take people who are larger in size, but my nursing home does. And yet, despite that, there was a lot of bias I was seeing day to day from my patients, whether it was the comments that were said under the breath that they could hear, whether it was pushing them out of the nursing home because they were gaining weight, or all sorts of things that were going on. And I thought that there had to be a better way, and I didn't understand why we as a field, who are typically really understanding of diverse populations and do our best to meet people where they're at, this was just totally off the radar. And so that was really the origin story of this talk and me doing a bit of a deeper dive into this topic. I know that we have a diverse audience here, and we have a lot of non-medical people, and I'm so jazzed to see that. I do have to say that a lot of this is based in the medical realm, and it's based around older adults. I think a lot of it can be extrapolated to other age groups and different settings, although I do think context is really important here, and I hope that I'll be able to transmit that adequately. So just I say we have to always be cautious when we're transmitting material for other contexts, but I do hope that we can certainly have a discussion after in the Q&A about extrapolating some of this to other populations. And if I get too medical on you, if I start using jargon, I apologize in advance. I'm happy to back out of that. So please just let me know, and please feel free to interrupt me, but we will hopefully have enough time for Q&A at the end. I don't have any financial relationships, and I do want to acknowledge the contributions from my colleagues who have contributed to this material. I'm using everything with permission. Aruna Josila, Paige Hector, and Michelle May. Let's jump right in with a clinical vignette. This is Mrs. Smith. This is a fictitious case of an 80-year-old woman who has a lifelong history of overweight and weight cycling. She's tried to lose multiple times and the weights come back. She recently moved into a long-term care facility after completing rehab for a stroke. This left her with hemiparesis, which means that one side of her body is weaker than the other. And this has limited her mobility. Her current BMI, body mass index, is 35, which puts her technically in a range of what we call obese. And other medical issues include dementia, high blood pressure, and osteoarthritis. I apologize for some of the formatting here. Apparently there was some duplicates. She's at the home and she begins to gain weight. So she's put on a calorie restricted diet. This temporarily yields some weight loss and followed by a rebound. The staff begin to criticize her food choices, including her trips that are made to the vending machines for snacks in between meals. And then this leads in turn to some escalating staff frustration with a number of staff needing to facilitate personal care and safe transfers. So before we go further, let's think about our thoughts and feelings around that we might be having around her rising weight and her weight loss efforts, her snacking behaviors. What thoughts and feelings might Ms. Smith have around her weight and these staff interactions? So let's zoom out and again, thinking about our own reactions to Mrs. Smith and people like her in larger bodies. We might need to consider some common views and how obesity arises and what it's like. Many folks in the community feel like it's a simple calorie equation that can be easily manipulated. Likewise, a common view is that one's weight is a choice and is therefore arrived over time by eating and/or sedentary behaviors. It would then follow that one could easily reverse overweight and obesity by eating less and exercising more. And this line of thinking can then readily be boiled down to one of attribution, that individuals are responsible for their weight, and therefore individuals who are overweight have a certain set of character traits and behaviors. And this typically is along the lines of them being lazy, unmotivated, or lacking willpower. This prevailing view of attribution is also aligned with many variations on cognitive processes. So let's go a few similar but slightly different definitions. When we think about weight stigma, this is the wholesale devaluation on a social basis and denigration because of someone's excess body weight that they're carrying. And this is slightly different, but related to a weight-based stereotype, which is a generalization about persons with overweight and obesity. And those generalizations tend to have ripples into other character attributions. And sometimes that leads into frank discrimination, which is prejudice, and then the translating to behaviors of unfair treatment of persons with overweight and obesity. Sometimes all of these processes going on can contribute to an internalization of weight bias, where the person feels a sense of self-blame and self-directed weight stigma. They truly believe that this is their fault and they're devalued appropriately in society. And then if we think about the different forms of weight bias, it can come in two flavors, either explicit or implicit. Explicit is overt, consciously held, and usually stated out loud, and measurable by self-report. And I would say that it's interesting if you think about the different types of bias for other types of marginalized groups. I feel like people, oftentimes as there's more awareness of bias and stereotypes, discrimination, people tend to go from explicit and then it goes underground into the more of the implicit, or at least just people don't feel a sense of being able to say this quite so openly. But I really hear it all the time, explicit weight bias in this realm. And whereas implicit weight bias is still very dangerous, it's automatic and unconscious. And you can almost argue that that's the most dangerous, when people are doing things automatically and unconsciously and maybe attributing it to different things. So where do we see this play out? Weight stigma is fairly ubiquitous and probably only the surface level of our consciousness, impacting every sector of society. We see it, there's been data that's borne out again and again, discrimination in employment settings. People are not hired or paid fairly or promoted at the same rates as thinner individuals. Even in our young children, those who are overweight, they will be discriminated against not only by their peers, but also by their teachers, and there's less expected of them in many settings. In healthcare, and this is the focus of our talk, we see this a lot in terms of less patient-centered care and not even taking concerns seriously for those who are overweight or obese. We don't invest in the resources that these folks need. And certainly in the media. So we have a thinness ideal, and higher weight people are not represented fairly. And when they tend to be stereotyped and maligned in terms of their character traits. And for many of us, our own history of bias towards higher weight individuals might manifest, might provide us a disconnect, an uncomfortable disconnect between our high order values that are tend to be based on our cortex and our implicit biases, which may show up in our behavior and our speech, especially when we're under stress. And it's within these lower centers that we're not necessarily responsible for all this. This has been a lifelong history of cultural messaging. Again, it's really in the water, this idea of weight bias and devaluation of higher weight individuals. So again, it can be uncomfortable for us to think about this, but I just want to present it as an idea that these things can paradoxically exist in the same person. We might think at our higher order levels that we treat all patients equally. We don't carry bias against people with larger bodies. And our brainstem is in the background, always churning based on that cultural messaging. Oh, geez, if they just had more self-control. And that's kind of how it can show up. And that, again, especially when it's unconscious, that can really exert a lot of power over our behaviors. So there are many ways that weight stigma and bias might show up in healthcare for patients with larger bodies. And these are just a few examples, certainly not exhaustive. Our offices and our facilities might lack the equipment necessary to provide proper care for somebody. We might over-focus, really zoom in on weight loss and dieting in the context of a visit that might be for something completely unrelated. We might apply labels and judgments to patients. Again, you're too fat, not compliant. These have been studied that are more likely to happen to higher weight individuals without any data to back that up. We might use dismissive body language. We might do rejection and shaming behaviors, and we might make wildly false assumptions about someone's abilities or their underlying character just based on how they look. Weight bias and stigma can have real impacts upon individuals, both mentally and physically. There's a risk of worsening or developing new conditions, worsening function and disability, worsening mortality, and even more weight gain is pictured here. If we start over on the right, we can imagine that bias gets internalized, translates to chronic stress, which then results in physiologic stress and can then lead to more weight gain and a vicious cycle. When might bias then and stigma transform into someone experiencing trauma? We're going to do a little bit of a segue into this concept of trauma and how it plays out for people in larger bodies. And as a start to that, let's take a look at the CMS, which stands for Center for Medicaid Services, Medicare and Medicaid Services. Let's take a look at their definition of trauma for some clues. And note in red that there are three main components to this definition. We have first, the event or circumstances themselves. The experience of those events are perceived as harmful, and then those are encoded to have a lasting adverse effect upon the individual over time. So this definition helps us to really embody the idea that, especially when bias and stigma occur over the course of years or are pervasive in an individual's life, this can be a recipe for trauma. I thought it might be powerful to hear directly from someone who's been through this. So this is a clip from a podcast interview with Aubrey Gordon. She's a prolific author as well as an activist for larger bodied people. And I highly recommend anybody pick up one of her books. But this is a short clip, and I hope everyone can hear it. It's going to come through my speakers back to the Zoom. I think it's really powerful to hear her voice of an experience of trauma.
A lot of people carry sort of trauma and hard feelings about their bodies and how their bodies were treated and regarded growing up. And I think what that means is often for people who don't wear plus sizes, I think they imagine that to be the sum total of sort of issues with body image, right? It's sort of like, oh, people have said hard things to me, right? And that felt really hurtful. And that's as far as I go in the conversation about body image, right? Growing up as a fat kid, it wasn't just about saying mean things to me because I was a fat kid. It was about getting sent to fat camp, which is, for folks who are unfamiliar, I think like pretty clearly just a way of giving kids eating disorders, and in some cases like pretty clear-cut abuse of kids happening in those spaces, right? It was about being put on not only on diets, but also being put on fen-phen, which was a diet drug that was pulled from the market because it stopped people's hearts. It was about, as Kara mentioned, like this whole idea of like not fitting, right? Like not being able to get a choir dress that fit unless you had one special made, and not being able to get a uniform size for a sports team, right? Like that sort of at every turn, you're not only not expected, but you're not welcome, right? And the only way to get welcomed is to transform your body into something it has not ever been. And that is a real hard way to grow up in the world, knowing that the only way, or being told that the only way that you can be accepted is if you change almost completely. I mean, like, I am also a queer person who works on campaigns around conversion therapy, and I will tell you the similarities there are often really striking, right? There's no evidence that that kind of transformation is really possible for most people, but there's a deep investment in making sure that people who are outside of the norm are sort of face some punitive circumstances for being outside of the norm, and that feels really bad and gross. Feels really bad and gross.
That's always a tough quote, a tough clip for me to get through, but I think it's very powerful at the same time. And I want us to take that clip and think about the fact that Aubrey's talking a lot about her early life experiences and young adult experiences, and how, if we think about how those might land and stay with her into her 7th and 8th decades as she becomes an older adult and possibly enters into a nursing home. How might those experiences be affecting her even then? I think it's fair to say that those experiences are going to be with her probably throughout her lifespan. And it's important for us who work with older adults to be considering that in our trauma conversations.
Oops.
And this is a great quote from Eleanor Barbara, who's worked a lot in long-term care. And I just want to put a point on it. By the time people get to older age, and especially to the post-acute and long-term care setting, which is a nursing home, they're carrying a lot with them. And she believes that virtually every resident coming into long-term care has been traumatized, at least to some extent, by the health event that precipitated their admission, the medical procedures they've undergone, and being away from home and other losses. And I would extend that to the traumatic experiences that have carried with them, especially when a person is more marginalized for whatever reason. So therefore, it's worthwhile to consider a universal precautions model around trauma in the same way that we do this for infectious hazards in the nursing home. Consider that everyone has trauma from something in their past in some regard, and engage appropriately with that. So when we think about the lens of trauma-informed care and what this calls upon us to do in the healthcare realm. It really is a radical shift in perspective. It goes from asking what's wrong with them to what has happened in this person's life and how is it affecting them. This may sound simple, but it requires a lot of unlearning of our usual ways of approaching patient care and our professional training that focuses on deficits and instead asks us to consider their stories, their trauma, their strengths, and partner with them in an individualized way. Trauma-informed care encompasses these 6 categories of practice that is a whole talk unto itself, but I want to go through them briefly to give us a sense. These are safety, attention to cultural, historical, and gender issues, trust and transparency, peer support, collaboration, mutuality, and empowerment, voice, and choice. It might be very easy to think about how we already do each of these in our day-to-day. I also think it would be honest to say that many of us can see how these might get lost when we're so consumed with other priorities in a busy day, especially in a healthcare setting. And I also want to highlight this great article from Paige Hector, one of my colleagues, who for the first time really applied trauma-informed care principles in the nursing home space. PALTC is sort of an acronym that means nursing home. She applied trauma-informed care to the nursing home space. It's really a call to action, and I encourage everyone to read it in full. I'll highlight a few paraphrase points here. These are considerations for people with larger bodies in long-term care. Do your larger residents feel safe in your community? Do they trust your staff and medical providers? And are they willing to share personal information, which may include feelings of shame? Are you partnering with between staff and residents and families in decision-making with power differences tended to? And how do you integrate a strengths perspective for each resident? For those unfamiliar, a strengths perspective is really looking at someone's unique attributes and what they enjoy doing instead of what might be lacking and applying guidelines that might apply to that, that might not apply to them or might be impossible for them. This is really common in the healthcare setting. We look at them and say, well, you're at this weight, but you're supposed to be at this weight. You're supposed to be doing 150 minutes of exercise per week, but yet you can't walk, and we don't necessarily individualize that. We don't look at their strengths, we look at their deficits. And she also asked us to do empathy training for our staff, teaching them how to cultivate empathy. In the nursing home, we ought to be speaking transparently about weight bias and at least acknowledging that it exists, and then also strategizing on how to address it within the facility. She asked us to consider inclusion of body size into our facility's DEI plan. I'll let you know that a lot of facilities don't have a DEI plan. So again, it's about building from the ground up. She asks, are staff adequately supported and trained to do their jobs well when caring for larger residents? We'll get into this a little bit later, but there are a lot of structural attributes to nursing homes that make it really difficult for staff to do the right thing, even if they're very motivated to do so. And does that home have a consistent, adequate supply of equipment, beds, commodes, shower benches, gowns, and et cetera, to maintain safety, dignity, and trust? And I would say beyond those attributes, letting someone know that they belong and they are okay as they are. So you might be thinking at this point, well, that all sounds great, but what about the structural barriers to trauma-informed care for larger residents in PALTC or nursing homes? And then from there, what can I do from where I sit? I don't control all of these systemic forces. Well, those are great questions, and we'll get into that a bit. So there are a lot of structural forces in play for larger patients in long-term care, particularly in the COVID era. For those who are unaware, nursing homes are really struggling. They're struggling for staff. There's these old buildings that were not built for larger bodies, and there's no money coming in to update them. And we have a limited supply of equipment. And what do our patients who have larger bodies typically require? They require more staff for personal care. Those staff need to have specialized training to care for them properly and safely to protect their own health. They need specialized equipment that is not going to break, for moving, especially for moving larger folks or for accommodating a larger body size. And they need specialized physical plant accommodations, such as wide doorways, larger tubs, and showers. All of these needs add additional expenses that at this time are totally unreimbursed by CMS, the Center for Medicaid and Medicaid Services, the major funding source for nursing homes. And in turn, this makes it difficult for the facility to accommodate larger patients. This in turn usually leads staff to be frustrated when they're encountering a situation with a larger patient, which gets passed down to the resident in the form of shame and blame. If I'm feeling frustrated as your nurse because I'm needing a lot of people to turn you, it's often not in that person's skill set, especially in the setting of a lot of cultural biases, to absorb that and know that I'll pass it on to you and think about you as flawed and causing all of this and bringing this upon yourself. So I think that's the typical pattern. The other pattern is that a lot of nursing homes will not accept folks who are over a certain weight because of these factors. And I just want to show some compassion towards the nursing homes. With this slide, the idea being that there's it's a very complicated arrangement here. This is not all bias. This is a lot of unfunded expenses that larger patients will sometimes require. And it's a difficult position for these nursing homes to find themselves in, and the staffs to find themselves in. So I'm a certified medical director, which is a very small group of people around the country who have taken special courses and training to be the leader of medical services within a nursing home. And I gave this talk to some medical directors in Albany earlier this spring and really emphasized these points about the role of the medical director. We often have small staffs within the facility, but we have a lot of influence, and we can use, I think it's within our scope of practice as a medical director to influence the care of all of our residents, including the most marginalized and those in larger bodies. And we can influence all of these different groups. We're like a big family with lots of different sections in the nursing home. And I think it's our obligation to use our abilities to influence policies, procedures, cultural norms, what is said and not said. And I like to say I've done this to the best of my ability so far. But again, we can talk to our PTs and OTs, our therapists, about having specialized equipment. Why don't we get it? If this person, exits the nursing home at some point, you could use that specialized wheelchair for the next person, or that specialized bed, or that specialized brace. Let's get this equipment in and not have to, make it seem like a big ordeal. Let's normalize equipment for larger bodies. And how could we create individualized strength-based therapy goals for people and not just, judge them against the people who are at different places? Again, using that strengths-based perspective. Our administrator, this is the person who holds the purse strings. We can advocate with them, again, for liberating the funds to purchase specialized equipment and to getting the facility in a place to accept larger patients into the building. For our director of nursing, otherwise known as the Don, and the nursing staff, we can really emphasize staff training to safely care for people with larger bodies and creating an inclusive environment. I had a resident, a patient who noticed, she was very sharp cognitively. She noticed that people were criticizing her, using slurs right outside the room. And so this was several years ago now, I sat down with our director of nursing and the nurse manager to say, we have to set an expectation that is unacceptable. This is a resident here just like everybody else. And again, I think it was the first time anybody had actually sat down and advocated for this patient, and she appreciated it. There was a change. So I like to think that having that influence was, I use that well. Transportation needs are very tricky. There's just not a lot of them in the community, but I think we need to understand what the resources are for transporting patients of size, get creative, and advocate for systemic changes to have more options. Our dietitians, we can work with them to align the food recommendations, the dietary recommendations with other important aspects like the resident's choice. What do they enjoy and what's their best options for quality of life? Our social workers are our best advocates typically for reinforcing the trauma-informed care model and educating staff and collaborating to address weight trauma for individual residents. There are some trauma questionnaires that our social workers are often in the best place to administer. There's a department called rec therapy within every nursing home, and we can work with them to create activities that are inclusive and accessible for people with larger bodies. And our facilities people can adjust the physical plant to meet the needs of our population, including those of size. So at this point, to take another little break, we can say, you know, maybe inclusion and advocacy are good things, but doesn't the science tell us that weight loss is a good thing and achievable if you just try? Aren't there some new options out there for weight loss? And by the way, I think there are, and these patients are starting to knock down my door for these drugs. All good points and questions. So let's back up a little bit before we get to answering those questions specifically. Let's zoom out and look at the heterogeneity of factors that can impact weight, especially longitudinally. It's not that simple. Everything from life experiences, genetics, environment, iatrogenic causes, such as iatrogenic means things that we do to people. So certain medications that people need will cause them to gain large amounts of weight. So these are called iatrogenic causes. We sometimes do things to people that affect their ability to their metabolism. What's not included here is that with normal aging too, the body tends to lose muscle and gain fat. These varied factors might just give us a bit of pause from oversimplifying someone's weight story, especially on their behalf. It also becomes easier to see how hard it can be to shift these forces to favor weight loss over the long term for many individuals. Let's also take a brief look at our good friend, the BMI. The BMI is now well entrenched in the medical literature. It's not going to go anywhere fast. And to be fair, what is good about the BMI? It's easy to do. You just need to know someone's height and weight. And for that reason, it may serve as a good screening tool. And it's good for population health data. It has yielded some validated results in the literature for individuals as well. Over a BMI of 35 is associated with certain health risks. So we don't want to diminish that. The BMI is found to be useful in that way. There are some notable limitations to the BMI, however. It has a fraught origin story, and it was developed in a non-Hispanic white population, and the category cutoffs are somewhat arbitrarily developed. They've shifted over time as well. And these breakpoints can be really meaningful to people. So I like to let them know that they're arbitrary. It's a spectrum going from class 1 to class 2, from quote normal weight to quote overweight. It can seem really big. And I just want to say that it's a spectrum and these cutoffs are somewhat arbitrary. It's also a relatively blunt tool. You are a column when it comes to the BMI. It doesn't take into account your gender, your ethnicity, your age, or your distribution of fat and muscle mass, all of which can have real impacts into interpreting your risk of health issues from your weight. All to say that important detail could be missed for the individual sitting in front of you. For instance, your patient in front of you might have had this exact same weight 10 years ago as they do today, but they may have substituted some of that muscle mass for fat mass, and the BMI would just let that go. It doesn't notice any of that change. So it's a blunt tool, and it's not a substitute for assessing an individual's health status, and certainly not making any assumptions about their behavior. Further complicating matters, for many older adults, the risk of weight loss might outweigh the benefits of losing weight. There's a well-established, quote, obesity paradox with older adults that are 65 plus. We know that those who are at BMI from about 25 to 33 are at the lowest risk of mortality compared to those below 25 and above 32 to 33. So that's just to say that even though someone might be technically in the overweight or obese range, so you're technically overweight at a BMI of 25, you need to keep in mind that especially for those folks from 25 to 33, they're at lower risk of mortality and other complications than those who are at lower weights. And that might be because a lot of folks do end up losing weight towards the end of their lives because they're ill. And so certainly for that population, and these are our nursing home patients actually, for our patients who are losing weight or at the lower end of the spectrum, we should not be advising weight loss because there's little to no longevity benefit. And there could be risks for losing any further weight for people who have limited life expectancy and are otherwise very ill. So we need to just first do no harm there. Also, if we're considering a weight loss program in somebody, we might need to consider all these potential side effects of that weight loss, especially when they're losing weight at a rapid clip or a lot of weight. Older adults are more at risk for malnutrition and malabsorption than younger adults. If they lose it fast or a lot of weight altogether, they can be at risk for low blood pressure and falling, and they can be at risk for losing muscle mass and having brittle bones. We also know that weight cycling in itself can cause some harm towards our older adults. There was one really well done study that showed, they measured muscle mass by DEXA scan, and they found that older adults, as compared to younger counterparts who lost and then regained as much as 3% of their body mass, tended to replace that lean muscle mass with fat mass. So the weight cycling in itself can be harmful in some cases. And also for our people who have a history of eating disorders and other trouble with that, we can certainly be re-triggering of those old cycles for when we go into a weight loss regimen again. So what about the old-fashioned way, diet and exercise? And by diet, I mean caloric restriction. While lifestyle literature is notoriously difficult to conduct, and it's also all over the map in terms of the programs that people are put on, it's now becoming clear that we can't really, over the long term, be successful in losing large amounts of weight for the vast majority of people with diet and exercise alone. There are lots of reasons for this. Our adaptive mechanisms perceive starvation, and that we slow our metabolism. Our appetite drive increases. And also, it's just really hard over the long term to avoid all the things in the environment and the cultural forces. If your whole family is eating Thanksgiving dinner in a certain way, it's really hard over the long term to avoid all of that. So it's not a fair fight between the cultural environment and also our internal cues that are really revving up, taking in more to maintain that body mass. And by contrast, I don't want to sound nihilistic towards supporting healthy lifestyle behaviors. Healthy lifestyle behaviors are very different than weight loss. And actually, the evidence does support, of course, recommending healthy lifestyle behaviors that we all know and love, eating plenty of fruits and vegetables, getting plenty of sleep, getting plenty of exercise to whatever extent we can. Those things, independent of weight, support our physiology, can improve metabolic diseases. And the vast majority of us are now aware that there is a new era upon us, and it has made this conversation much more nuanced. And I welcome the evolution of this conversation as it goes on. I imagine if I give this talk in a year, it'll be slightly different. But these GLP-1 medications are a game changer, and I don't want to deny that. As opposed to diet and exercise, which is not going to be successful for people over the long term in the majority of cases, the GLP-1 agonists really do have ushered in a new era of a potential for folks to have a sustainable way of losing weight. And just to review, the FDA has approved these 3 medicines for use in people who have an elevated BMI, independent of their diseases that might be associated. So again, these are real options out there for people, and many of us are knowing people or on them ourselves who may have used them, and we only know it's a relatively new and evolving strategy for weight loss that is only going to change. We're going to know more information as it becomes available. With that said, there is still limited efficacy and safety data for the older adult group. Only one study I could find of the GLP-1 medicines studied in a 65+ group that showed good efficacy and overall safety, though these patients dropped out at higher rates than younger folks due to the GI side effects. And so again, we have to think about older people being at risk for what I mentioned before. With the appetite suppression and the possibility for rapid weight loss, they might have malnutrition, they might have orthostasis, which meaning low blood pressure causing falls, they might lose muscle mass, and they might have brittle bones. Also, we can't ignore that there are cost and access issues. Medicare and Medicaid are not yet covering these medicines for the indication of weight loss alone. They will cover typically when they're used for an indication of diabetes that results also in some weight loss. Private insurers are all over the map right now, and people unfortunately are finding that their insurance might cover it for a year and then they're not covering it the next year and they have to scramble. So that's a really disorienting type of environment to find yourself in, especially if you're feeling the benefits of it. And there's these drug shortages that we can't control. So these are just things to kind of consider when we're thinking about picking up the prescription pad. Many of us in geriatrics tend to overlook bariatric surgery as an option for our older adults, but I just wanted to include this because it's a fair thing to consider for the right candidates as a effective, safe, and durable option for people who are looking to lose a large amount of weight. I will say that in practice and then in the studies, it's mainly the 65 to 75 age range that surgical weight loss is being done. We really need to have caution when thinking about the nursing home population, our frailer patients, and also those 75 plus, because these patients are frailer, they have more medical problems, they're less likely to be good surgical candidates. They're likely to have risks of surgery and then post-operative risks, and more likely to have that malnutrition type of thing going on, and other risks of low blood pressure, et cetera. So a lot of our nursing home residents won't be probably great surgical candidates, but we should know about the various procedures, including the risks, so that we can properly counsel them. And also you're going to have increasing numbers of older adult patients ending up in nursing homes who have had surgery in the past, and you need to know about their ongoing risks related to malnutrition and malabsorption. So the final part of this talk is about, okay, knowing all this, how do we get to person-centered trauma-informed care? What's something I can take to the bank in terms of my approach to patients in the setting? First, when it comes to having conversations, obviously this can be fraught, especially with what I presented. There's a lot to consider when entering into a discussion with somebody if you're going to discuss their weight. And I would just say it's fair that you don't always have to talk about it. Especially some people feel like everything they go into the doctor for, whether it's a stubbed toe or they're depressed or something, it always, like, there's this magnetism that gets back to their weight. So I would just say there's permission to not always have to discuss it. It depends on the visit context. It depends on your relationship before going into in-depth discussion. And be mindful that well-intended comments, oh, you look great, did you lose weight? Like they can stimulate a lot of stuff for people, especially if there's that trauma history in the back. And you need to consider your power differential, especially if you're in a high power position compared to this patient. That's important to be mindful of. And I've gotten into the habit of anytime I'm heading into sensitive territory, I pause and I ask if it's a good time or ask permission. It's really about, meeting someone where they're at. If it's not a good time for them, I back away. It doesn't usually benefit me to plow right past their boundaries. And if you are going to have a discussion, listen, take in the story, which it might include but not limited to, how has their higher weight and any weight bias they've experienced impacted them? What are their goals and values with regard to their health and their health care? For a lot of our older adults, they're transitioning more into a phase of being, okay, there might be, again, I don't want to oversimplify, but a lot of them are less concerned with aesthetics. They really just want to have maybe relief of pain. They may not have the same values as you do, and having some humility about that is important. And certainly discuss any weight-related health risks and barriers empathically without blaming. You can just say, there's this risk at your weight without blaming them for that. And it's a subtle but important difference. When making treatment decisions and reasoning through somebody's health, just really making sure we disentangle what their weight is, what their diseases are, and their lifestyle behaviors. There are a lot of people who are very thin who eat fast food 3 times a day and don't get a lick of exercise, but we may just think that they're having really healthy lifestyle behaviors, and the opposite of people who are higher weight. So really just disentangling that, not making assumptions, do the appropriate objective screening tests without assuming. And zoom out, not having that magnetism that everything relates back to their weight. And think about what the practical ways that you can promote health for this person are outside of their weight. And really think objectively, is their weight causing any problems or not? Consider treating a person for obesity only if they actually have markers for poor metabolic health. And this next one might seem like a no-brainer, but it really isn't. Take the health concerns of a larger person seriously, without minimizing or blaming them. And a good thought experiment to this end would be, how would I treat a thin person who presented with the same concern? What tests would I put them through? How would I ask the questions? Because a lot of times we're just taken out of that mindset completely and end up minimizing it. And then lastly, avoid blaming residents or patients for encountering difficulties as a result of their weight. And a good thought experiment to this end, as I mentioned at the beginning, is like, how do geriatricians especially, we're so good at navigating barriers for other patients who have difficulties, but yet we don't typically do that with larger patients. So we have a patient with dementia. How am I going to navigate? How am I going to meet this person where they are? Or someone who needs an interpreter because they have limited English proficiency. I get them an interpreter. I don't blame them for not being able to speak English with me, for instance. And when it comes to documentation, the record is it can be a minefield when it comes to, how we speak about the patients and the terms we use. A lot of times, even if we're sensitive with our conversation, we end up writing things in the record that are really discriminatory and really laden with a lot of judgment. So we need to be aware of that and work to mitigate any of that. And unfortunately, our coding, our quality indicators do actually reinforce all of that bad language. So we have a lot of work to do systemically to get rid of that. And if we're going to document about somebody's weight, really do it in a patient-centered way. What's their history of the weight? Again, how have they interpreted that? What are their goals, values, concerns? What are their barriers to optimal care? And how do you see their health issues and or risks? So to kind of wrap it all up, if I want to bring this back to Mrs. Smith, and if you recall, she's an 80-year-old who just went to the nursing home from rehab after a stroke. She's got a lifelong history of dealing with overweight and obesity. Her current BMI is 35. She's had a stroke. She has mild dementia, meaning some thinking problems, high blood pressure, and arthritis. And she's got this escalating issue with the staff. She's been put on a restrictive diet, and they don't like her going to the vending machines. Their staff unrest with also the extra care that she requires. My first, if I learn about this as her doctor and as the medical director, I'm going to go to the nurse manager and I'm going to just really gather the data, get the nurse manager's opinions, get to a shared reality, so to speak, of the situation, really using empathy and curiosity and collaboration, really working to not make it a who's right and who's wrong type of situation, which we totally can get into. I want to empathize with the fact that this nurse manager is probably put in a tough spot if a lot of her staff are needing to care for Miss Smith because of her size. And, she has some sort of goals that are not being met and some needs that are not being met. And her staff are complaining to her. I can empathize with all of that without necessarily buying into the narrative of what she thinks is best. We can work together. I then do a medical review. And based on the situation, the information we have from this patient, I don't think that I would advise that she lose weight. First, it's not clear that her obesity is associated with or driving any other medical conditions. I don't think it's going to affect her length of life. In fact, many of the difficulties that are being brought to my attention are at the nursing patient staff level. And that's where we ought to put our attention. Further, her history of dieting and weight cycling I'm going to guess that it's been traumatic. Again, using the universal precautions, I'm guessing that she has some trauma wrapped up in that. And all these efforts to get her to diet could be re-traumatizing. And I don't know if a GLP-1 would be accessible to her financially, or if it would, be overwhelming in terms of side effects. And it's not well studied. So I'm probably not going to recommend that she try to lose weight at this point. As a starting point, I would put her on a regular diet because the restrictive diet is not working. It actually might be forcing her to go to the vending machine for more food. And I would review her medications. I would look to see if we're doing this to her to some degree. I'd look for more weight neutral options. I'd try to deprescribe, which means get rid of medicines that aren't working for her. And then I would advocate for her and other residents at the facility level. I'd be talking to my dietitians about the freedom to choose the quality and quantity of foods without pressure or commentary. And I would also be talking to them about the lack of benefits and potential harms of restrictive diets. I do find that anecdotally that when we give people more freedom, they don't feel the need to like hoard as much. So there might actually be a lot of benefits to having more freedom to choose quality and quantity. Again, we can choose healthy foods. We can offer healthy foods to people without restricting their quantity. And also I do some nursing education with safely caring for people with larger bodies and creating an inclusive atmosphere, no matter where they are. So as far as takeaways, I hope I've been able to make the case that there are pervasive cultural biases and structural barriers towards larger individuals in multiple settings, in particular healthcare, with real impacts. And healthcare is not immune to this. It's difficult and important work to navigate caring for older adults with obesity in a person-centered and trauma-informed way. This is not something that happens overnight. It's a lifelong effort that takes skill and creativity, resources, and advocacy. So it's something that I think as long as I just try to do it day by day, it's important and fulfilling. And so when we think about weight loss treatment, especially in this new era with a lot more options for people that might be sustainable, it's a really interesting time. And I'm not trying to be a wet blanket on all of these new treatments, but we need to proceed carefully, especially for older adults who are perhaps more at risk of harms of these medications and the weight loss itself, and maybe not within their goals. So we have to, again, remember the old adage, first do no harm, and remember what matters most to this patient in front of me without making assumptions. And so with that, that's all my content. Thank you for listening, and I'm happy to take any further questions. And I hope we have a few minutes for Q&A at this point in time. I think I stopped sharing.
Yes, we definitely have time for some questions and comments, and we can either put them in the chat or I open it up for people just to throw their questions out there. I'm really appreciative of the way that you've given us different ways to think about it or talk about it. And I'm wondering if there's any like resources, like, so if we want to take it on as like, how do I advocate for this? Are there resources that you can suggest that we might be able to, put our hands on? Or
I have a great handout in which I incorporated into that last piece about communicating and documenting and thinking. It's mainly for healthcare professionals, but I can certainly pass that along. It's a great one-pager with a lot of resources. I do unfortunately think that this being such a new topic, at least of an awareness, that we really are at the beginnings of understanding and finding that there's not a lot written about this in general. I think the best we can do at this point is apply these frameworks like trauma-informed care, person-centered care, and think about it. I think a lot of us could creatively think, how can I apply these frameworks to folks of size?
good point.
And that's all I've been doing, actually. That was the origin story of this talk, really. How do I apply these frameworks to this population? And I think, again, a lot of other ratings for other marginalized groups will translate well. You can kind of take what works in your mind, because a lot of the feelings are similar. Like, again, meet people where they are. And I think a lot of the dementia literature would also resonate with this work. People with dementia have a lot of capabilities and they're evolving over time, and we want to emphasize their strengths. I just went to a lecture this morning about really thinking about the strengths and unique attributes of people with dementia. And I think a lot of that really applies. If you're having a PT program for a larger bodied person who maybe is strong and yet has some mobility impairments, don't think of them as just impaired and, oh, I can't get the right equipment. How can we think about what they do have? Maybe they have good upper body strength, but their leg is weak. Can this person hoist themselves up and use that muscle mass in a way that helps them navigate the world a little better?
Definitely.
I see Beth is asking, what percentage of nursing home populations do you feel fall into the obese category? And thank you. You're welcome. I wish I had better, I don't know if I have that data at the top of my head. And all I can say is that I think that that percentage will go up over time. Because our population demographics are trending more towards heavier folks in midlife, us in the nursing home, seeing people typically towards the end of their life, we're always seeing things, 10 years later from the trends, right? And so I think that's why I want to do this now, is so that hopefully as systems and as individuals, we can get prepared, because we are going to be seeing more and more folks who are entering our nursing homes or needing nursing home care, because again, sometimes they don't let them in the door, who have these needs, and we need to be prepared to accept them and treat them like human beings, in the same way that we do for other people who have other advanced needs.
Oh, great food for thought. And I think, your comment about it being 10 years down the road, that like helps us really try to be a little more mindful of that. And also the thing I just struck with is the systemic or the structural things. And I'm just wondering if you have any advice for, like, say, the long-term care committee that we're working with, hospitals, organizations, long-term care. What can we do as a committee, do you think, that might help with the things we need to do?
I would love to see an advocacy effort. I think organizing and really bringing this into the consciousness of the people who hold the purse strings and also the policies, because unfortunately, I think policy is going to have to drive reimbursement. We have other examples in nursing home world of, for instance, ventilator units or neurobehavioral units, people with specialized needs, people who need a chronic ventilator. The nursing home gets a specialized rate for that. And I would love to see an enhanced rate, so they get a little bit more money to care for the individual with a specialized need. I would love to see that in the future for people of size who, again, have legitimate needs for specialized training of personnel, specialized equipment, and that does cost. And so I think we're going to need dollars, which is going to, before that you get dollars, you're going to need policy and organizing.
Right. I want to be mindful of the time, because I know you took time today out of your busy schedule. I would imagine if there are any other questions, feel free to send them to me, and then I can get them forwarded to you, and we'll work on getting the presentation and that together so that people can see it at a later time. But thank you so much for coming and spending time with us in Tompkins County. We're really fortunate to have you as our speaker today.
My pleasure. Thank you so much.
All right, thank you. Thanks everybody for attending.
Bye.